Okay, welcome everybody to an exciting webinar that we have planned today that is being hosted by the Patient-Centered Primary Care Collaborative, otherwise known as the PCPCC. And this is Rob Dribbin. I am going to be moderating today's discussion. The discussion topic for today is entitled Integrating Physical and Behavioral Health, the View from Primary Care Providers and Payers. Before I introduce our speakers, wanted to share a couple of important points prior to their presentation. So as you can hopefully see, everyone can see the screen and follow along on the web. If there's any technical issues, significant technical issues, please, you can send in a question to bring it to our attention, but it looks like everything is working okay at this point. So as mentioned, I'm Rob Dribbin. I am one of the two executive member liaisons working alongside of Julie Shills. The two of us serve in that capacity, working closely with the PCPCC Board of Directors and also the executive membership. The points that I wanted to mention before we get to our speakers, importantly, the PCPCC holds an annual conference each year. This year, the conference is scheduled for November 8th, and it's in Washington, D.C. You can go to the registration site at www.pcpccevents.com. And just a couple of key points I'll share with you about the conference. The conference really does reflect the membership of the PCPCC. It's a very, for those of you who are not as familiar with the PCPCC, it's a highly diverse organization. The membership, it ranges from virtually all parts of the healthcare system. It's quite a unique group and a very important organization, especially with the power from so many different parts of the healthcare system behind it. And the topics we'll touch on at the annual conference. The wide array of topics. If you're looking for strategies of how national and state and private sector policy leaders are increasing their primary care investment with a focus on how that investment might increase over the next 5 years, then this is an important conference for you to attend. If you're interested in learning about different models of care, advanced models of care, from patient-centered medical homes all along the continuum, then you certainly want to attend this conference. It's not just about the traditional stakeholders anymore. It's about employers and technology disruptors and many other players and stakeholders in the system who are going to be participating in the conference, and also the topics will cover the way in which these organizations are making primary care more accessible by reducing barriers and also personalizing healthcare. And also, importantly, innovation is a key element of the conference that will take place in November. It always is each year, but it seems like it's heightened from year to year. And the focus this year will be on innovative approaches to primary care delivery that's shaped by input of patients and families, as well as by innovative clinicians, business coalitions, researchers, and primary care advocates. So I'll underscore the importance of the role of the patient. I just mentioned it, but everything does truly center on the patient and their families. So we hope to see you at the conference on November 8th. Please check out the website that you see on your screen. And you also have opportunities in the third bullet point down to join the PCPCC as an executive member. And there will be, for executive members, there is a members-only workshop that's entitled Investing in Primary Care, Advancing a National Strategy. So those separate workshops and discussions are highly valuable, and we hope that you consider joining the PCPCC as well. And as mentioned, if you're interested in gaining more information about joining the PCPCC, please contact Allison Gross at the address that's listed there on your computer. And lastly, I'll just mention that very exciting that each year, a couple of years, there's, in this case, it's the annual evidence report, so it isn't a yearly report that's produced by the PCPCC, and that's going to be released on August 8th of this year. So stay tuned. It's an important paper and report that is produced from year to year that shows the evidence behind these emerging and existing models of care that are focused on better, more coordinated, more effective primary care. So please stay tuned for that and look for the annual evidence report on August 8th. So with that, the focus of today's discussion, as I mentioned before, is about integrating behavioral health into primary care. We have a few speakers today. I'll go through their bios, and we're going to have a good discussion. We're going to hear from them first, and we're going to open it up after we hear from each speaker. So first, we'll hear from Bruce Landon, who is a professor of healthcare policy at Harvard Medical School and a professor of medicine at the Beth Israel Deaconess Medical Center. He practices internal medicine at Beth Israel. Dr. Landon's primary research interest has been assessing the impact of different characteristics of physicians and healthcare organizations, ranging from health plans to physician group practices on physician behavior and the provision of healthcare services. His work in this area has included the development of theoretical models to explain how healthcare organizations affect the quality of care, and he's now involved in several projects that will help describe and quantify the impact of a variety of organizational characteristics and strategies, including quality improvement strategies and financial incentives on the provision of care. He'll be co-presenting with Russell Phillips. Russell Phillips, Dr. Phillips, is a director of the Center for Primary Care and the William Applebaum Professor of Medicine and Professor of Global Health and Social Medicine at Harvard Medical School, along with Bruce. He's a devoted primary care general internist at Beth Israel Deaconess Medical Center, where he cares for more than 250 patients, many of whom he has known for more than 20 years. With the center, he leads programs that are transforming education and care systems, developing entirely new approaches to improving primary care and health, and performing research on high-performing health systems and practices and the impact of changes in payment and primary care practice structure on the finances of primary care practices. So they'll be first up today, and then they'll be followed by James Schuster, who is, Dr. Schuster is a VP of Behavioral Integration and the Chief Medical Officer for Behavioral, Medicaid, and Special Needs Services for the UPMC Insurance Division. Dr. Schuster is a board-certified physician in psychiatry and in the subspecialties of geriatric and addiction psychiatry. He leads teams that have secured several awards for the Patient-Centered Outcomes Research Institute and other funders focused on integrated care, shared decision-making, and medication-assisted treatment. After we hear from Bruce, from Russell, and then James, we're going to have Dr. James Kingsland react. And James Kingsland is the senior partner in a renowned general practice in the northwest of England. He has extensive experience in general practice, medical education, and medical politics. He's president of the National Association of Primary Care, having previously served as chair of that organization. He's the author, or co-author, I should say, of the new care model, the primary care home, as it's known in England, and is one of 2 national leads for the primary care home program across the country. So I'm going to turn it over to our speakers in just a second. I do want to just set the stage, and you'll when you hear from each of the presentations with Bruce and Russ going first, and then followed by James Schuster, they're going to be approaching this problem of behavioral integration from 2 different perspectives. So when you hear Russ and Bruce, and then you hear James, you'll probably pick up on they're coming at this from 2 different angles. So with that, I'm going to turn it over to Dr. Bruce Landon.
Okay, thank you very much, Robert, for that introduction, and my thanks to the PCPCC for organizing this session. So I think we have a lot to cover, so I'm going to get right into it. All right, hang on one second. Let me just make sure I have control. So could we advance the slide, please? Thank you. So I think it won't be a surprise to anybody who's calling in to the phone today with interest in this topic that mental health is really one of the most common issues affecting people throughout the country. So here I'm showing you data from Ron Kessler's National Comorbidity Survey replication. It's about 10 years old, but I would say there's really not much new. If anything, maybe these numbers would have gotten worse. And I show this here just to demonstrate the extremely high frequency of mental health problems in the general population in the U.S. For instance, we can see that over the course of a calendar year, about 18% of people are diagnosed with a real or have symptoms that are consistent with a diagnosable anxiety disorder. And of these, over half of them will be considered moderate or severe. Similarly, over the same period, about 10% are diagnosed with a mood disorder, and the majority of these are going to be moderate or severe. And you can see the similar numbers for impulse control and substance use disorder. Importantly, you'll see below that about just over a quarter of people in the country experience one of these problems, one or more of these problems over the course of a year. Now, obviously, if you add up those numbers, it comes to a number that's substantially more than 26%. And this suggests that these problems actually co-occur in a lot of people. So first point here, these are very common conditions. So in the next slide here, you can see some of the treatment-seeking behaviors of patients with mental health problems. And the main message here that you can see is that there's a huge number of visits per 100 population where mental health diagnoses are coded, and even higher numbers where a psychotropic medication is prescribed or continued. And these numbers of visits vastly outnumber the number of visits to psychiatrists or other mental health professionals doing psychotherapy. The implication of this slide is that that care has to be happening somewhere else. And in general, that's happening in the primary care setting. So on these 2 slides, I've tried to make the argument, number 1, mental health conditions are incredibly common, and number 2, even when the system isn't particularly well set up to do it, most mental health conditions are getting their primary treatment within a primary care setting. So when we think about the delivery of mental health services in primary care, there are a number of challenges that primary care physicians and practices face. First, there's a lack of reimbursement for screening and prevention. Even though we're all doing things like the PHQ-2 and the PHQ-9 as regular screening tools in our practices, this isn't something that's paid for an extra. There's also a lack of, until recently, and we'll talk about this in a little bit, of reimbursement for collaborative care and case management. Within many Medicaid programs, there's an inability to bill solely for mental health services. And there's severe limitations in the ability to bill for physical and mental health services in the same visit. For instance, if you're providing 20 or 30 minutes of mental health counseling, that would really be a time-based visit. You can't then, in addition to that, bill another evaluation in the management code to cover the other treatment you did for physical health problems. And then, of course, there's a lack of training and comfort level among many primary care physicians. Yet we also know that settings where collaborative care is used probably lead to improved outcomes. So here I'm just showing you an example of of a prominent paper that was done of collaborative care that was published in the New England Journal back in 2010. So this was a randomized controlled trial that had hundreds of participants. And here you can see that those in the collaborative care arm versus the usual care arm had better outcomes across the entire spectrum of care. Their rating of global improvement improved in 45% versus 18% of them. There was better control of their hemoglobin A1Cs and their systolic blood pressures. There was a 50% decrease in their symptom checklist score, which is something that measures how their depression's doing, going from 30% up from 60 to 30%. There was much higher satisfaction with their depression care. There was much higher satisfaction with their chronic care, and there are actually even improvements in quality of life. But of course, so the question is, how can we sort of promote the adoption of these kind of care models in routine practice? So now I'm going to take a step back and tell you a little bit about our simulation model that we developed. So obviously, when you're considering payment reform and other structural reforms for primary care, there's lots of things that can be done. And practices are going to be reluctant to do these things without actually having some data to show that it's going to be something that will work out for them. So we developed this microsimulation model to inform policymakers, because practices and policymakers lack the tools to estimate impact of due practice and payment models on practice, finance, and outcomes. And we also know that current practice structures are not optimized to deliver high-value care, and in particular, they're not optimized to deliver collaborative care for behavioral health. So a key assumption to our modeling, and I think this is something that we think is really important to carry through, is that it's not rational to expect primary care practices to implement changes that adversely impact their costs and revenues. The current model of primary care, which most of us would agree doesn't work very well, evolved under a fee-for-service payment system that's not really well matched to the tasks that we ask primary care physicians to do. And similarly, we can't ask them to do a whole bunch more things related to collaborative care and depression, for instance, or behavioral health screening, and expect them to do that at a financial loss to themselves. So a little bit more about our modeling approach. So modeling is used extensively in other fields to model investments and financial decisions. It's really nice because it's a safe space to write down all the possible assumptions and scenarios before you actually go pilot experiments. It also allows you to test things over many different types of settings. It's a technique that determines which decisions have low uncertainty and which have high uncertainty, and to identify future research needs. And it allows us to broaden generalizability beyond single pilot projects because of our ability to look across a whole spectrum of practices, treating a whole spectrum of patients. Next slide, please. All right, there we go. So we use a microsimulation model, which is a simulation of individuals in a population that simulates individual patients with complex histories and comorbidities, as well as their insurance coverages and their socioeconomic characteristics. And then we group them together into individual clinics with complex panel, staff, costs, and revenues. This is what's called high data, low assumption modeling, where we really bring in as much data about practice revenues, finances, and costs as we can capture. The modeling approach is able to capture nonlinear relationships and feedback loops, and it's very flexible in the things that we can do. The disadvantages to this approach are that lots of computer power is needed, but luckily we've been doing these on servers that are designed for predicting weather at Stanford, and lots of data are needed. So now that I've defined the problem of primary care and behavioral health and made an argument for why integration would be a good thing and told you about our approach a little, I'm now going to turn this over to my colleague Russell Phillips to tell you about the specific analysis that we did related to behavioral health integration.
Thank you, Bruce. As Bruce summarized, what we've developed is a model that enables us to test the impact of new payments on finances at the primary care practice level. As Bruce summarized, we make assumptions that primary care practices are going to do the things that are supported or that make a positive margin. In 2017, Medicare passed some new codes that I'll refer to as G codes, which can be used to actually pay for behavioral health integration to primary care. And so what we chose to do was use our model to test the impact of these new codes on actual deployment if they were deployed within a primary care practice. We viewed there as being there are two major models of behavioral health integration to primary care. One we refer to as the embedded behaviorist model. The second is the collaborative care model. I'll describe these in some detail and then also talk about some of the codes that are used to pay for these services. First, the collaborative care model, which happens to be the one of these two models that probably has the best evidence base supporting it, involves care plan development, often including pharmacotherapy from the primary care physician, and then a master-level behaviorist who's providing follow-up care by phone. It requires periodic psychiatrist or psychiatric nurse practitioner PA review for Medicare payment. There are actually 3 different G codes that pay for these services, and I won't go over these in detail, but they are called the G0502, 0503, and 0504. If you want more detail on these specific codes, they're actually, that detail is provided in a paper that we published in the Journal of General Internal Medicine on this analysis in 2017. The second model is an embedded behaviorist model, and this is a model where there's a behaviorist working within the practice. So this is often a psychologist or a psychiatric social worker, and they're providing brief time-limited behavioral treatments. This can be paid via traditional billing mechanisms for psychologists, licensed clinical social worker visits, but also can be supplemented under the new G codes as well. And here the G codes that apply are G0507 and G0507. This figure shows how these different models work in practice, and I'll go through them just very briefly. To your left, under collaborative care, we see that patients who are affected by some of the conditions that Bruce referred to, depression, anxiety, alcohol use, substance use, and tobacco use, come into our practices all the time. They're found through a variety of different screening techniques, and then there will be subsequent initial assessment and a treatment plan created by the primary care physician. In practices that have collaborative care, there's a care manager who will provide follow-up, who will essentially maintain a roster of these patients and then make sure they're getting appropriate follow-up over time. In all cases, severe, high-risk, and treatment-resistant patients will be referred outside of primary care practice. And what the care manager does, or the costs associated with the care manager, are the costs of employing that person, the services they provide, their office space, as well as the supervision that's provided by a psychiatrist or psychiatric nurse practitioner. And then the payment in our model comes from Medicare. In the next column to the right, under behavioral care, the primary care behaviorist, we see similarly patients are coming to the practice, similarly they're screened for, similarly there's initial assessment and treatment plan by the primary care physician. But here follow-up is to a primary care behaviorist who works within the practice and will often do short-term and limited psychotherapy to care for these patients, again with payment from Medicare and with costs that represent the behaviorist salary, the training of primary care physicians for coordination, and the required on-site space. The Medicare payment rates are also detailed within our paper, but just very briefly for collaborative care management, the G codes pay $140 for 70 minutes per patient for the first month, and then $125 for 60 minutes per patient for subsequent months. And remember, this is for care management activities. And then the primary care behaviorist model pays $48 for at least 20 minutes per patient per month, in addition to the standard Medicare PIC codes that reimburse for behavior services. This figure shows the way that we did our modeling. And first, we were interested in looking at what the impact was on different types of practices in different settings. So as one group, we looked at federally qualified health centers. A second, we looked at non-federally qualified health centers, but urban practices that are practicing within a high poverty zone, and then non-federally qualified health centers that are rural, that are also in a high poverty zone. We then broke down the distribution by payer groups, and they were split into Medicare, Medicaid, private, and self-pay or uninsured. We identified the prevalence of the behavioral health conditions that Bruce referred to and that we've referred to in this presentation that include anxiety, depression, as well as alcohol and tobacco use. And then we looked at the costs within the collaborative care model, which are listed to the left, and the primary care behaviorist model, which are listed to the right. I'll very briefly give some of the results, and again, these are given in more detail in the paper. In the collaborative care management model, the time for care management or behaviorist over a year is estimated to be about 1,200 hours, and the cost annually after year one for full-time equivalent physician is about $16,000. The net revenue in subsequent years per physician FTE is about $33,000. So the bottom line is that practices make money on the collaborative care management model, and this is in federally qualified health centers that are serving Medicare patients. In the behaviorist care, or primary care behaviorist model, you can see that more time is spent on the care manager and on the behaviorist. The cost is higher, and the net revenue is actually lower, to where it actually loses money over time. These results look at the urban or rural lower poverty zone and show that, again, the collaborative care management model makes money, whereas the primary care behaviorist model loses money. Take-home points from this and my presentation and Bruce's are that mental health problems are extremely common, and most mental health care can occur within primary care practice. That traditional reimbursement models are poorly supportive of models that integrate primary care and mental health, but that new Medicare billing codes, particularly for collaborative care models, might be an attractive method for improving mental health care and paying for it within primary care settings. With that, I'll pass the baton.
Great. Well, thanks to both of you. Now we're going to turn it over to Dr. James Schuster to take us through his slides. James?
Thank you, and thank you for including me in the presentation today. I'm sorry, I'm just trying to get this. There we go. Got it. So, you know, you just heard about strategies to address behavioral health in primary care, and I'm going to present a complementary strategy, which is addressing physical health and wellness issues for individuals with serious mental illness in behavioral health settings. So it's really how can we address these issues with when people are in behavioral health settings. So I'm from UPMC, which is an integrated delivery and finance system in central and western Pennsylvania. And I'm in the insurance services division. And the insurance services division includes a company called Community Care, which is a behavioral health managed care organization. And really this project grew out of Community Care. In Pennsylvania, the counties manage behavioral health services for individuals with Medicaid. They all partner with a managed care organization, and Community Care partners with 39 of the 67 counties in the state. So we have about 1 million members, and we're a not-for-profit MCO. So these are the counties that we work in within Pennsylvania. And the program that I'm going to talk to you about actually originated in a number of the rural counties across the northern part of Pennsylvania. So the background to this is actually individuals from several of these counties, both counties, providers, other stakeholders came to us and said, you know, we don't actually have many primary care practitioners in these rural counties, as well as not having many behavioral practitioners. So as behavioral health providers, and other stakeholders, we really want to try to develop strategies to better help the physical health of the people we're serving. So Pennsylvania was not one of the states that adopted the Medicaid health home payment incentive option, but we used key themes from that legislation to develop a behavioral health home based in a behavioral health setting. So we really tried to focus on a model that would accompany the ideas of the triple aim, and we used wellness themes that are embedded in the SAMHSA wellness model developed by Peggy Swarbrick to really inform how we would help providers approach patients and the strategies that they used. So these were some of the key behavioral health home components. That includes comprehensive care management, care coordination, engaging folks in primary care. Most of these sites did not have primary care services on site, but certainly part of the model was efforts to really help them better engage with primary care services, and also using health information technology, which I'll talk more about in a moment. So again, we began to develop this model back in 2010, and there were, I think, really kind of four key themes to the model that we put together to try to enhance services in really traditional mental health providers. So the first was that we financed the addition of a wellness nurse to the existing mental health team. So this really built on Ben Druss's work from Emory that indicated that having a nurse focused on physical health and wellness in mental health settings enhanced individuals' engagement in primary care. The second was that we used a coaching model, also developed by Peggy Swarbrick, to help case managers and peer coaches really learn how to engage individuals in addressing physical health issues, really using motivational engagement strategies. The third intervention was we helped the providers learn how to use a health registry. Many of these agencies had never before even used electronic health records, so we helped them learn how to use a health registry on our website that they could use to both identify individuals with significant medical conditions and track their interventions. And then the fourth was we developed some self-management toolkits for individuals with serious mental illness that really help them with things like sleep, energy, exercise, medication management, and so on. So again, these were, so those were some of the key interventions. Some of the key strategies that we focused on were really try to address gaps in care, engage individuals in enhancing physical health and wellness as part of their recovery approach. We really work with the agencies so that they establish reciprocal relationships with primary care and specialty Medicare providers, and that they would support screening for behavioral health conditions and history of stress, of traumatic stress. The wellness nurse was certainly a key position in the model, really focused on helping to provide informal consultation to other members of the team and do some direct care management for individuals with complex conditions. The nurse was also responsible for managing the registry of data that was sent out monthly to the agencies about physical conditions that their patients had, and helped other team members really use the registry to track their interventions. So we've implemented this model at a couple sites, really as demonstration efforts, and we got really positive feedback from both the patients and the providers. So we applied for an award from the Patient-Centered Outcome Research Institute to study two versions of the intervention. So the first intervention was what we call patient self-directed. It included wellness coaches, use of the member registry, and use of self-management toolkits by the patients at those sites. And then we compared it to what we call provider-supported, which also included wellness coaches and a member registry, but also included the nurse role. And we designed the study this way partly because really the incremental cost to the model was really tied to the nurse. So the wellness coaches were pre-existing case management and peer staff, and the member registry and the toolkits and so on were supported by community care, and they were kind of an upfront, mostly fixed cost. But the nursing position was clearly an ongoing incremental cost, so we wanted to evaluate the impact of that. In the interest of time, I won't go through these slides around the learning collaborative process, but we use the Institute for Healthcare Improvement's learning collaborative process. So it's a very structured plan, do, study, act cycle, and we provided a lot of structure and technical assistance to the agencies that implemented this. There were 11 agencies that participated in the sites that were evaluated by the award from PCORI. And they were in 2 learning collaboratives. One did the provider-supported model, and the other the patient-directed model. So we used a cluster randomized design. The people who participated were all Medicaid members, at least 21 years old, had a history of serious mental illness. In terms of the data sources, you can see we used a number of self-report measures. We did a number of qualitative interviews. We had data from implementation around the Learning Collaborative. And then we had eligibility, behavioral health, physical health, and pharmacy claims data. So the primary outcomes was that we found there was a significant increase in patient activation in both models of the health home. There was more rapid increase in the sites that had a wellness nurse. And generally, the Learning Collaborative suggested there was more rapid uptake of the intervention in the sites that had a nurse. There was significant increase in engagement in primary and specialty care in both models. And there was an improvement in perceived mental health status. There was a decrease in perceived physical health status, which we thought might be related to the fact people had a lot more information about their physical health conditions. We did a number of qualitative evaluations, interviews with both patients and providers. The patients were very favorable, and not surprisingly, they found the most important piece was their relationship with their wellness coach, who was either a case manager or a peer staff. From the provider side, there was a great deal of agency support, and we found that the interventions actually helped change the culture at the agencies. We didn't overtly measure that, but there was clearly much more focus on physical health at the agencies, even of the physical health of the staff as well as the patients. We did some subsequent and post hoc analysis looking at expenditures, and we found that the expenditures were lower in the model that included the nurses, and that the behavioral health spend was also lower. We then broke that out into some details. IP is inpatient, and you can see that in year 2, it looked like there was a trend towards lower inpatient use in the nurse agencies. The behavioral health use was clearly lower in the agencies that had nurses, so it looked like the nurses helped organize behavioral health services as well as wellness and physical health, although that was their intent. You can see that medication spend, the RX, the medication spend was higher in the first year, so we hope with the nurses, so we hope that means people were actually getting more engaged in treating their illnesses. The case management expenses, TCM, total case management, targeted case management expenses were lower in the model that had the nurses, which was interesting because the funding for the nurse actually was funded through the case management rates. But even though we paid for the nurses in the case management piece, the total expenses were lower. So it looked like actually having the nurse participate was, even though it was an incremental expense, it was cost effective. We then looked, and I'm sorry about the typo under RX and psychotropics, but we found that there was lower spending in utilization and total cost in the individuals who were in the study versus a comparison group. So the comparison group was post hoc. They were not part of the randomized evaluation, but we found that they had lower cost, or it looked like there was certainly a trend for lower cost in the study group compared to the comparison group. And if you look particularly at the nursing group versus the comparison group, there was the costs were about 30 to 40% lower compared to the comparison group. So it looked like this intervention both improved the quality of care, got people more engaged with their primary care physicians, and also lowered, in particular, inpatient use and cost. The driver of the lower inpatient use was actually there was lower behavioral health inpatient use, but on the physical health side, what we found was that physical health inpatient use also went down, but physical health outpatient costs went up. So it looked like people got more engaged. So since we've had these positive results, we've actually since expanded the model now to about 50 agencies across the counties that we work in, and most recently received an additional award from PCORI to disseminate the model to residential treatment programs and to opioid treatment programs. So I'm going to stop there and turn this back over to the facilitator. So again, thank you for including me in the presentation today.
Thank you, Dr. Schuster, much appreciated. And now we're going to hear from our reactor, Dr. James Kingsland, who's in England, I believe, as we speak, and he's going to react to what the speakers have shared. James?
Rob, thank you, and good evening, everybody, from, yes, West Kirby in England. That's not far from Liverpool, and where are we at? 8:45 in the evening over here on a dull, rainy evening. Contrary to what you may have been hearing about the heat wave in UK, it's pretty heavy rain at the moment, but that's usual for us. But really interesting presentations and similar principles about the integration of care, particularly about physical and mental health well-being. But I guess one of the challenges is talking about it in a very different payment system from the National Health Service. Probably one of the questions is about how much of the reform, the care reform, is dependent on payment reform. But probably just a reflection is that integrating behavioural health with physical health, intuitively, whole person, personalised, complete care for an individual is the right thing to do. And there's always a question, why is it so difficult? In the UK, we still have mental health trusts separate to sometimes primary care. We have difficulty building the right clinical services or the right people within a primary care setting when, as we've heard, there's a large presentation. We recognise that in general practice in England, probably 40% of all presentations to the general practitioner, the family physician, have a significant mental health problem. And we also know that a lot of the long-term NCDs that we deal with, for example, type 2 diabetes, 40% of people with type 2 diabetes suffer with depressive illness or depressive episodes. So we know it's a problem linked to other conditions as well, but we still have this this disconnect sometimes between the management of mental health and behavioural health with physical health. We also have something that we often discuss, therefore, as a result of this disconnect, about parity of esteem, where sometimes we do develop services based on the physical needs of individuals, and then say we need to have a parity of esteem with mental health, but have the paradox of then disconnecting it from whole person care. So probably for our first two, Bruce, how much is dependent, because intuitively this care reform, you gave good evidence of why it should be an integrated service, but how much is dependent? Because we know that sometimes care reform is only sustainable if we have ultimately pay reform and then institutional reform. And not knowing a lot about, understand some of the Medicare and Medicaid payment systems, but is that going to be a significant trigger to be able to get this integrated service?
So I think that will be. So the second part of of our presentation that Russ presented was where we ran through some very specific Medicare policies that have been adopted over the last year or so to simulate for practices what would happen if they integrated behavioral health care into their model, with one of the models being much better than the other one. And so I think it's, as you're sort of implying, it's a necessary first step to have the right payment milieu. And now, at least for our Medicare patients, we might have achieved that. So the next step is going to be sort of, training programs and dissemination to try to get better adoption of these programs within primary care.
So secondly, just from James's presentation as well about the behavioural health home, again, the evidence that it does deliver the triple aim, but we've been focusing within our new care model called the primary care home on the fourth element of the quadruple aim of the providers of care, because again, intuitively, it does seem as though a lot of health and social care professionals do like working in teams. And when we're trying to build a team inclusive of mental health, it is around the clinical psychologists, counselling, community psychiatric nurses, visiting consultant psychiatrists. But do you have evidence that whilst you're improving patient experience, driving down per capita costs, that you are also measuring the providers of the care? Because we're recognising one of the biggest financial risks in our health service at the moment is the morale of the staff. And one of it is the disconnected care, the unnecessary transactions we have in different parts of the system. But have you evidence, again, that by delivering this, it's not only good for patients, but it's good for the people who provide the care?
Yeah, that's a great question. And I really wish we had been smart enough prospectively to kind of measure somehow objectively measure the satisfaction and engagement of the staff. We did do qualitative interviews, and the staff were very positive about the program, especially about having the nurse to support their engagement of individuals with medical problems. A lot of the feedback that we got from the staff was that, they know people, they knew their patients with serious mental illness had lots of medical problems, but they didn't really quite know how to go about trying to get them connected or engaged or talk to PCPs. So they were generally very enthused about the program. And one of the things that I alluded to was, this is just anecdotal, but it appeared to us that there was a significant change in the culture of the agencies as well. Many of them started new programs for staff, weight races or walking or running clubs or what have you, that really focused on the health of their staff as well as the health of their patients. So it's a great point. I'd actually be interested in hearing from you. We've also done a lot of work with a number of primary care settings, trying to enhance behavioral health services. And although certainly people like working in teams, the sense we've gotten is that the primary care settings are not as used to the idea or as experienced with the team model as a number of behavioral health settings are. And I was wondering if that's consistent with your experience, and if there are suggestions you have for how to move that theme along in primary care settings, or move it forward.
Yeah, it's interesting. We've had cyclical reform at each time we've attempted care reform within the NHS. There's always been a focus on cutting down unnecessary transactions, integrating services around the individual, and particularly about incorporating mental health care within a primary care setting. So we've had experience over probably the last 30 years where it has worked, but lots of issues, either the political cycle, institutional reform hasn't occurred, and payment reform hasn't. That's why I was asking about that. So therefore, often the teams that we've built have been broken down. We've returned to the medical model of general practice, and then realized a few years later we really should be having a team approach. So I think it goes back to our only success is when we've, as all speakers have demonstrated, we've got clear evidence that it's the right thing to do as well as being intuitively the right thing, and patient preference about collaborative care or complete care for their complex needs in one setting is again difficult to argue against. But we've always found that once we've built teams, the way to continue and make sure it persists is that the payment reform is really important, so that institutions who are aiming to work collaboratively but then have difficulties, financial difficulties or new ideas, will retract people from working in teams, and therefore it breaks down. So I think there's, again, asking in the early stages, that the contractual and payment reforms, once the service and team is built based on that evidence that you've described, is the way to make it sustainable.
Thank you.
Rob, I'm not sure whether, do I continue? I'm not sure questions that...
Yeah, James, thank you for that. I appreciate your reaction and discussion. So we're going to open it up for questions here. I'm going to feel free to send in questions and we can look at them online, but there's been a number of questions already that have come in. So I'll go down the list in no particular order. James Schuster, this was directed towards you. The takeaway from the individual who's asking the question is that an on-site nurse coordinator is key to impacting outcomes, and the individual is asking whether his or her understanding is correct or not.
We found that both models supported enhanced activation of the patients as measured by the patient activation measure. And the degree of change in the patient activation measure is associated in the other literature studies with decreased utilization of medical services. So we think, and clearly both models led to increased engagement in our own data in primary care services. I think that what we found was that the sites which had a nurse had more rapid adoption of the changes, more rapid engagement of members in physical health, patients in physical health and provider and wellness activities, and that they likely had, or at least there were trends that suggested they had an even greater fiscal impact. However, if an agency or a setting can't get funding for a nurse to support the other mental health staff, I think their results would certainly support that it certainly makes sense to make wellness and physical health attention an important part of people's overall recovery plans, and to provide education and training to staff in how to do that.
Got it. Thank you. Another question came in about G codes. How do the new G codes fit in with value-based contracting, or is this primarily seen as a strategy for those still in fee-for-service?
That's a great question. So I think these are really seen as a strategy within fee-for-service, as a way to start paying for non-visit-based services and to support mental health integration in primary care. At least, if anybody else has different knowledge about this, please correct me, but I don't think these would be used within a value-based payment, unless the system were also using the G codes just to distribute monies around when there might be capitated payment, for instance.
Yeah, I would just make one amendment to that. So in many value-based payment systems, like Medicare's Accountable Care Organization model, for instance, still rely on a fee-for-service backbone. And this is still a way to distribute and adequately restore primary care within that model. And I think many people would argue that the increase in investment in primary care, particularly for these patients, might have payoffs in terms of downstream spending, and it clearly will have payoffs in terms of adequately resourcing the primary care system.
Great. Thank you for that. Here's another one. I'll answer this one. It's a quick one that I could answer quickly. A couple of questions came in about who the members are of the PCPCC. So you can go to the website, PCPCC.org, and find the members, the executive members, of which there are about 55 executive members and about 1,200 overall supporters of the PCPCC. So be sure to go to the website. And here's another question that came in about, now we kind of got to the question before about nurses. Here, it's a challenge to fill workforce with only psychologists and licensed clinical social workers. And we use counselors and marriage and family therapists, which can't bill to Medicare. Is this an issue that was identified in your work, and is there anything being done to expand the workforce? This individual, for context, serves a large Spanish-speaking population, which makes it even more challenging to have the workforce that is billable by Medicare. Thoughts on that?
Yeah, so we didn't really model based on the availability, of specific members of the workforce, but rather modeled on those that potentially could be billed for to provide services. We recognize that in many places there's a shortage of mental health services for patients, or the availability of those who can provide those services. In fact, in the Center for Primary Care, we're very interested in exploring models where community health workers are uptrained to use script-based cognitive behavioral therapy for patients with anxiety and depression, and are sort of trying to learn from international models where this is done commonly to see whether it could be deployed in this country.
All right, thank you. Well, we're bouncing up against time here. Any additional questions will be posted that we didn't get to will be posted on the PCPCC.org website. I do want to acknowledge the turnout for today. We had over almost 400 on this webinar today. So great to hear so much and see so many people interested in this topic. Clearly, the speakers drew those folks into today's discussion. So I'd like to thank Bruce Landon, Russell Phillips, James Schuster, and James Kingsland for their leading of the discussion today. And with that, we hope, again, you look for the PCPCC annual conference online for registration, and we hope to see you in November, on November 8th in Washington, D.C. at that conference. So with that, I'll close and thank the speakers and also the PCPCC staff for hosting today's discussion, and I hope everybody has a great rest of the day and week. Take care.